Hi, I'm Dr. Carey Roth Bayer, Associate Professor in the Departments of Community Health and Preventive Medicine and Medical Education at Morehouse School of Medicine, and I'm excited today to be joined by Dr. Jason Satterfield, Professor of Medicine and Director of Social and Behavioral Sciences in the School of Medicine at the University of California, San Francisco. Also, Dr. Melanie Davis, President of Honest Exchange, and Dr. Lee Jones, Associate Dean for Student Affairs and Professor of Psychiatry and Behavioral Sciences at the University of California, Davis School of Medicine. Good morning and welcome.
Good morning.
Really excited today to talk with you. And just starting out, Jason, if you could tell us a little bit about some individual barriers that you've encountered that have made it challenging to include LGBT and DSD content for faculty development.
Sure. So happy to talk about some barriers, but wanted to share just a little bit too about, I guess, a perspective that I found to be helpful. I think in general, the assumption that I like to make is that individuals, teachers, they want to do a good job, they want to provide equal care, they want to be good role models, but oftentimes there's both internal and external factors that make it hard for them to realize and to achieve those goals. So if we're looking first just at a personal level, obstacles for these individuals, there's the usual attitudes or awareness, knowledge, and skills. They may not be that familiar with the LGBT or DSD affected communities. There's also the ever-present issue of time. There's just not enough time to do their job, to teach about the different areas of medicine that our patients might be bringing to the table or that our learners might be bringing to the table. The last thing, though, which I think is probably a little bit trickier to get your hands around is, I guess I'll call it intrinsic motivation. So we're motivated to do a good job and to be good teachers, but it takes more than just that general motivation. Given there are hundreds of different topics they could potentially talk about, how is it we're going to highlight that one particular topic and help them to see the relevance? And I think there's two things really that we should probably try to promote. One is about decisional balance, so seeing the advantages or the disadvantages of doing it or of not doing it. And the second part has to do more with, we assume that people are rational, but we're not always so rational. We're also emotional beings. And so they need to have ready access to personal, poignant stories from their peers, from their colleagues, from their family, from their patients, so that they really understand in their head, but also in their heart, why it's so important.
Are there other individual factors that you can think of that may impede or make it hard to include LGBT and DSD content?
I think one reason is understanding the importance that we often focus on people like us and people like them, instead of seeing we're all in this pool together. And so we can't leave out when we teach any group of people, just because it might be a little more challenging to teach about that group. So it's sort of getting this internal sense of inclusion, but it's also having the time, as you mentioned, the time, teaching the students this is important. This is no less important than illness or diagnosis. This is understanding people and their behavior and their motivations and identities is equally important.
Leah, if you could talk a little bit maybe some systems barriers that we've encountered.
Sure, happy to do that. I think they very much parallel the individual ones, that time is a huge thing in priorities, that medical curricula are completely packed. Most faculty have 5 or 6 jobs, and so where does this get added in? So I think time's a big one. Another one is lack of leadership, perhaps, or of advocates or a champion. Many times these kinds of initiatives depend on 1 or 2 people standing up and moving it forward, which can be both a wonderful thing, but if that person leaves, can be problematic. So I think there needs to be institutional ownership of this as an initiative. The third is also parallel to the personal one, which is there may be conscious or unconscious bias on the part of the leaders on the institution, and certainly medicine historically is a fairly conservative practice. We like to think of ourselves as moving forward with new innovative technologies, but we are frequently slow adapters when it comes to lots of other things. So I think that for example, there are insurance companies that have been working in diversity much longer than we have in medicine, and much more successfully. So I think there's some inherent human things, there's some large systems issues that make it difficult to incorporate change in an already overpacked situation.
Are there any other other systems issues that you can think of?
Yeah, I just wanted to add, I think you made a terrific point about the potential implicit bias, and I think every faculty member, or most faculty members in most institutions, have an explicit ideology of wanting to deliver equal care and wanting to have equitable teaching about all populations, and they have an explicit appreciation of diversity. But those faculty, those individuals in those institutions are part of a larger society where things aren't equal, where there is bias, where there is prejudice and discrimination, and it is inevitable that those same structures are going to work their way into our teaching.
You know, and I think the other thing to add is that looking at outcomes, when you're practicing as a physician or a clinician, you realize that there's multiple things that contribute to successful outcomes, and we often forget at the teaching level when we're introducing it to students that behavioral issues are huge, and feeling comfortable and feeling addressed and feeling included. You can prescribe the right medication, but if the person hasn't made a connection or felt understood, that completely affects the outcome. And getting people to understand that at an institutional level, that this isn't just the soft added thing, that this is an important part of care.
Well, and another issue is that when we talk about issues like sexual identity, in a curriculum that we're used to testing on, what's your pre and post knowledge? Well, you can know the words, you can know the definitions, but you're not going to be a good clinician unless in your soul you are comfortable with the types of patients that you're working with. You can't test that. That's something that you have to live. And so if we're in a system that values how are we measuring this? It's hard to measure affect and emotion. So it's easier to say, well, you can test on the definitions. So we have to figure out how to educate in ways that will encourage learning that isn't necessarily based on test scores.
I think that's really important, and it also leads into, maybe you can talk about some strategies that have worked over time for how to include content on LGBT and DSD health.
Well, one of the first ways is, you can do the definitions, certainly, and get people to understand the differences between gender identity and sexual orientation. So that's more of a definitive kind of thing. But as you mentioned, having people have personal stories, bringing people in to a classroom, bringing in panels to answer questions, to tell their stories about how they've interacted with the medical system and with individual providers. Maybe they found a provider who was wonderful and made them feel comfortable disclosing their identity, or maybe they had a horrible experience with somebody who just couldn't break through that. So introducing a personal element is often very effective.
Other strategies that you found effective?
Well, I think oftentimes with this sort of program or similar programs, you want to start with a needs assessment. So every institution is different. Every institution has different levels of curricula that exist already. So starting maybe with a curriculum mapping of what do we have and where is it taught and who actually teaches it and does it reach all of our students? What are the resources that we have? Who are the internal champions that might be able to step in and to pick up pieces of this curriculum? Do we have buy-in from the leadership? Do we also have bottom-up support from our students and from other folks? And if all of those pieces are in place, then you know that you have really the resources necessary to put whatever strategy it might be in place.
You also mentioned that you have an interdisciplinary program, and I think that one important thing about that is that the obvious person is not necessarily the best person to teach a topic. So if you look at the resources that you have on staff and the faculty that you have on staff and really think, oh, well, that's a person in psychology, but on this sociological angle, they can really hit that better.
So at least what I'm hearing is that there may be some less obvious places that people are not traditionally thinking about that could be a great fit for infusing content. So sometimes we learn the most from those approaches that we've tried that maybe haven't worked so well. Can you talk a little bit about maybe some of those strategies that have just really not been effective for kind of lasting change and getting content in?
Sure, I'll start with that one. I think there's a variety of issues that have come up, things that we've tried. Clearly, as you alluded to, straightforward lectures and slides and PowerPoint doesn't do the trick here, because this is about feeling and thinking. There's certainly a lot of facts we need to know, but being able to connect with the stories and individuals is important. I think the strategy, hoping that it's going to bubble up from below without a champion or a leader or buy-in, is problematic. Having it set aside and not integrated is problematic because it becomes marginalized or may become marginalized. So something less than integrated is problematic.
I mean, one thing that can help is when medical students in particular are used to listening, digesting, seeing slides, when we teach about sexuality topics, often it's helpful to break out of that box and get people up on their feet and moving around. So, because they're thinking about the activity rather than the intellectualizing the right answer. So things like values voting. Do you agree with this? Do you disagree with it? Why do you agree with it? How do you make this feel? These behaviors, are these healthy behaviors? Are these unhealthy behaviors? And really getting them to think about, well, this is a behavior that my patients eventually may participate in, and I feel really uncomfortable with it. Okay, accept that you feel uncomfortable with that, but that's a choice that your patient is making. So how are we going to help that patient make that choice in a healthy way? But you can't get to that discussion point unless you've already moved them out of this box where they're just watching a slide and memorizing what's on the slide.
So moving into those standardized patients, actually
Standardized
practicing.
patients are great because they have to actually interact, and then they have somebody observing and sort of coaching along with that. Mm-hmm.
Other strategies that you've seen that maybe haven't been quite as effective?
Well, I'm thinking more not of a particular strategy, but of the context behind a strategy, maybe different strategies, and specifically I'm thinking about institutional culture and leadership. That you can have the best strategy, you can have the best program, you can have a groundswell of students and junior faculty wanting to teach about these issues. But if there isn't a leadership that supports it, if there isn't already an institutional culture which supports and promotes change, which evaluates and gives feedback to teachers and is interested in continuous quality improvement of those teachers, then those strategies probably aren't going to be as successful, if they're successful at all. So part of it is starting from the bottom up is wonderful, but you need to start from the top down and have the right leadership and promote the right sort of change culture.
I think part of that picture too is identifying where your curriculum, who controls the curriculum, and how do you influence that curriculum. And I think you've identified some different ways, which leads into my next question of, if you were going to give advice on how to put a plan in place, what might that plan look like for including more LGBT and DSD content in the medical school?
So I think you'd have to start, as you said, with a needs assessment, looking at what's already being taught there, because you may be surprised what's being done already. You may be surprised at what's not being done already. I think doing your homework, so being prepared to come up with the why this is important, which includes finances, outcomes, it's the right thing to do, it improves patient care. Moving on to the how in your proposal for leadership, how can this be done? Making use of resources to make it easier for the people that are going to be moving it, and collaborating. I mean, meeting and talking with people across the country that are at various levels along this process would be very helpful as you move forward with this.
I think also asking the students what they're actually getting, because the curriculum may say this is a human sexuality course, but it may focus on contraception, on reproductive behaviors, and not actually get into sexual identities. Also, what's the student behaviors? When they're in a lecture and they're learning about whatever the sexuality topic is, are they studying for something else while they're attending that lecture? That's one of the benefits of doing affective learning, is that they can't be doing two things at once. They have to focus on the activities as opposed to just taking notes. So I think really not just talking to the leaders and looking at the map, but actually asking on the ground level, what are the students experiencing when they're in that program?
I think attending to the hidden curriculum too, because often what we find is you can cover a lot of things in the first 2 years in the more traditional didactic part, but if the practice that they see when they hit third year is different or is not as cohesive, it can undermine what was taught in the first 2 years. So I think being integrative, you've alluded to that a couple times, that looking at it across the entire 4 years of medical school and hopefully into residency and training beyond, that it's a priority, that everyone gets that.
Tell us a little bit more about what a hidden curriculum is.
Sure. So there's the non-hidden curriculum or the overt curriculum, which is here are the goals and objectives. And then there's the hidden sort of messages behind that about here's what's really important. Here's what we do. Here's, so an example, a non-charge example that comes to mind is we always teach people to not listen to the heart and lungs through a shirt, that you need to be at the chest. But then when you hit third year and fourth year, you see that, in the clinic, people frequently don't have patients take off their shirts. So they're doing it. So what's the message there? Do as I say or do as I do. And I think that becomes even more important when it's something charged like sexuality, because people are naturally uncomfortable with that. And so they're much more likely to follow the lead of the person that they're seeing whom they admire, who is now where they want to be. They're the neurosurgeon, they're the internist, they're the family medicine doc. And if we don't hit those people and include them as part of this overall effort, it makes it more difficult. And it's a little bit confusing, I think, to the student about what's the right thing to do. And I think we need to be very clear about that.
And that takes us back to that issue of awareness, because I'm sure those faculty are not aware that they're sending an implicit message, a hidden curriculum message saying, don't do as I said, do as I'm modeling right now.
For efficiency.
Right.
Right.
I think the other thing is also to spread it across the curriculum so that there isn't one class in LGBT DSD that they're running into that throughout all the years of their program. And familiarity is a huge part of opening your attitude and affect toward other kinds of patients, whether it's about sexual identity or cultural identity, but just really repeated exposure and seeing people in healthy states and less healthy states all across. So you don't identify people with a state of being that's just people.
Kind of the whole being and an aspect of identity.
Mm-hmm.
So several of the discussion points has reminded me of really a principle or a philosophy that I think most schools try to follow, and that's one of bringing in the science, and not the science of medicine, but the science of teaching, and thinking about not evidence-based medicine, but evidence-based teaching. We know something about how people learn, and we know that the one-stop didactic lecture is not particularly helpful, that you want it integrated and spaced over time. You want experiential learning and practice. You want supervision with feedback and elaboration. You can do online curriculum mixed with video, mixed with in-person, so multimodal teaching, and all of that's important. Unfortunately, the way things are now with faculty development, we probably know less of the science of how to train faculty. NSF supports the training of science, technology, engineering, and math teachers, but we don't have an equivalent body that supports the science behind faculty development, or at least not yet. Maybe one day.
Which is kind of a good segue into, you talked about institutional systems, you talked about leadership, faculty, students. What other resources might institutions or faculty be able to tap into to help look at infusing their curricula with content across the program?
So I think, first of all, again, going back to a needs assessment and looking at who are your internal helpers, who are the people that are already there doing this work that you can call on to and enhance their work, looking at collaborators and colleagues across the country to see what's being done. Why recreate the wheel if it's already been created? And there's a lot of resources out there. AAMC is a great resource. Unconscious bias work, diversity work, cultural competency work. Fenway has modules that you can actually download to educate people. So there's a lot of resources out there within particular areas that address these kinds of things.
I think also taking advantage of for example, the Philadelphia Trans Health Conference, getting people, both faculty and students, to attend conferences where they will learn about the issues, integrate, mingle with people who are dealing with those issues, both as consumers and as professionals serving those consumers. So the resources are not necessarily always curriculum, but sometimes it's just health conferences, health fairs, maybe bringing in people who work with these populations who may not look like medical doctors, but may have experience in the field.
Right. And I think another useful resource, at least one I've certainly found useful, goes back to the very first International Conference on Faculty Development in the Health Professions was in 2011, hosted by University of Toronto, and that was recently published as an edited volume. It's simply called Faculty Development in the Health Professions, and it goes through a summary really of all the evidence of what do we know about how to teach faculty, a variety of different topics, what interventions work, what hasn't worked, how do you change systems, and how do you take this to the next level at your institution.
I think one last thing I'd like to bring up is ongoing assessment, and we've all talked about that, is that people are good teachers, but sometimes they don't understand why they're good teachers. And more importantly, people that are okay or not good teachers don't understand what it takes to move forward. And I think it's really useful as a teaching faculty member to get ongoing feedback about how am I doing, what am I doing, with hopefully someone that understands, what it takes, as you say, to become a good teacher and how to develop further with ongoing assessments.
Mm-hmm. Are there any other points around faculty development that we haven't covered that came to mind as we were going throughout this?
Well, I think one of the things that was mentioned was, that looking at it from the top down and getting that support, because the faculty may want to take more coursework to improve their work. But if there isn't time, if there aren't financial resources, because some of these courses are quite costly. So there has to be leadership at the top supporting this level of improvement, and creative ways of learning. So if you're going to go out in the community and attend conferences, maybe providing the funding to fly across the country and attend a conference.
And also maybe tapping into your local resources. What agencies are around you? What resources do you actually have in your own backyard that you may not require necessarily a plane ride to a conference or accessing these videos?
Right. Well, and I think just remembering that this is always going to be a work in progress, that we will never be 100%, but that's our star on the horizon, that we want to care equally for every population, and we will do our best to get there. But we will all make mistakes, and we should all help to support each other in learning how to correct those mistakes and to be better teachers.
Mm-hmm.
Well, thank you for joining us today, and we look forward to future participation in shaping faculty development in the future.